My name is Terry Matthews, and I was invited to talk to you about the cancer patient's point of view and also communication with cancer patients. Why do I feel qualified to talk with you? I'll just give you a snapshot of my health background. In 1994, I was diagnosed with ovarian cancer. It was widespread. I had surgery, and just before my first chemotherapy treatment, I developed a heart arrhythmia. I went into the emergency room, and laying on that table, I knew, because the doctors told me, that if they couldn't reverse the arrhythmia, it would kill me within minutes. I also knew that my ovarian cancer had a really grim prognosis. And for the first time in my life, I realized that I was a heartbeat away from dying. We all are. But cancer patients have a very keen awareness of this. They tend to have thought of it far more than the average person. That visceral impact stayed with me. It is with me today. And the direction of my life has changed. One of the things I spend a lot of time doing is talking about cancer to newly diagnosed patients and talking to health professionals, hoping to make the world a little bit more patient-friendly. My treatment for ovarian cancer included 9 months of chemotherapy, another surgery, more chemotherapy, and about 2 years of regaining my strength. At the end of those 2 years, I developed breast cancer. It was unrelated to the ovarian cancer. It meant 12 more chemotherapy treatments, 6 weeks of radiation, and continuing hormonal therapy. I had surgery also for the breast cancer. Through all those years, I was gathering data on communication. I'd like to tell you my daughter's story because it explains a little bit about why I'm talking to you. When Charlotte was about 8 years old, we were sitting having a family meeting, as we did periodically, discussing chores and who would do what. Her brothers were probably 12 and 13. And at one point, her oldest brother said to Charlotte, "Well, you just don't want to mow the lawn. You think that because you're a girl, you can just do the house chores instead." And Charlotte absolutely blew up. She looked him in the eye, and just shaking with rage, she said, "You don't know what I think. You don't know 90% of who I am." And she stormed out of the room and slammed the door, and the rest of us were just stunned. We just had never seen this side of Charlotte. The other thing that struck me was that she was right. None of us knows what someone else thinks. We don't know 90% of who they are. And it's true for me, it's true for you, it's true for all of us. But a person who's undergoing cancer treatment has a lot of content in that 90% that you may not understand, and they will be too groggy or confused or frightened to tell you. So I'm hoping to give you some insight about the things that are not discussed or obvious. What are the dimensions of illness or health? They're physical, mental, emotional, and spiritual. The doctors and nurses do a great job of taking care of the physical. They check your blood pressure, they check your temperature, they poke, they prod. And they may say you're doing fine, when in fact you, as the patient, don't feel fine at all. Some of the things that patients suffer with physically are not recognized by their healthcare providers, and they tend to not be mentioned by the patient. For example, insomnia is a really major concern for a patient. It's awfully hard to get well when you're so sleepy you can't think. Severe fatigue is a real quality of life issue. If they find themselves having so little energy they can't walk to the car, that makes a big difference. Nausea and vomiting obviously can be miserable. Pain can be unrelenting. And the reason I mentioned these 4 things, insomnia, fatigue, nausea, and pain, is that there is a misconception among patients that they just have to live with it, that they've taken the medication and it didn't give them relief, so oh well, too bad. And they may not express these concerns to their doctor. If the doctor doesn't know that these are concerns, they can't be addressed. But they are very treatable, and that's the bottom line. There are many different medications that can be tried. They act in different ways, in different combinations on different bodies. So please, if you hear of any of these physical manifestations, encourage the patient or the family member to bring this up with their healthcare providers so that this can be addressed. It makes a huge difference. The mental components of illness tend to not be thought about much. They're rarely acknowledged, and they tend to just be lumped together under the title, the patient's upset. They can be present simply as a result of the trauma of a cancer diagnosis. But in addition, most of them are made worse by medications, especially pain medication in any form, and many chemotherapy drugs. What happens in your brain when you're undergoing cancer treatment? You tend to be easily overwhelmed, like a computer that's getting more data coming in than it can accommodate. There's a massive overload. The patient is flooded with information and emotions beyond what they can absorb and process. At the same time, they have huge, life-changing decisions to make about surgery, about chemotherapy, about doctors, about stepping out of all of the other activities of their life to deal with this illness. There tends to be confusion and uncertainty because the factors that are being weighed are unfamiliar, and so nothing feels routine. Everything is new. There's an impaired ability to reason, to follow a train of thought through to a logical conclusion. It used to be that A plus B equals C, but now A plus B might be M, or A plus B equals, where was I? What was A again? So it's definitely a different mental place to be. There are problems prioritizing because everything seems like the most important thing at once. Doing the research on your particular tumor, meeting the needs of your children, figuring out the treatment decisions that you will use. Even routine tasks. You can't just skip meals because you're busy doing other things. Everything feels the most important all at once. Many patients experience memory impairment, especially short-term following a chemotherapy treatment. I've always done the bill paying in our household. It's something I'm comfortable with. I've worked as a bookkeeper, and it's second nature to me. One month I had just had a chemotherapy treatment the day before, but I was feeling pretty decent. I certainly was having no problems, so I sat down to pay the bills and paid a stack of probably 15 bills. No problem, dropped them in the mail. And about a week later, I started getting phone calls and mail back to me. I had sent out checks without a signature, and I had paid one of the bills twice. This was something I never would have done before my illness. It gave me huge reassurance when one of the other patients said to me, "Oh, that's just Chemo Brain." And I said, "What? What's Chemo Brain?" And she explained to me that it was a well-known entity that affects patients during the course of their chemotherapy, and that it was temporary, and that I wasn't really losing my mind, but this was just part of the side effects of the treatment. There tends to be a distortion in the sense of time. A minute doesn't equal a minute, and an hour doesn't equal an hour. The nights seem to be about 20 hours long, and the middle of the day when the sun is out goes by in the blink of an eye. If a person is nauseated, it seems like they just looked at the clock every 5 minutes and they can't believe that the clock hands are crawling so slowly until they feel better. A 30-minute procedure can feel to the patient like a whole day of misery. The last mental component I'd like to talk about is sundowning. This is a term that's used primarily by people in hospitals and rest homes, and the term comes from the fact that it happens most often in the evening between sunset and the time the patient goes to sleep. What it is a hallucination. And I had heard of sundowning before my illness. And I thought, yeah, it happens to old people, it's not going to happen to me. But it did happen to me, and it was memorable. I was absolutely convinced, laying in my hospital bed, that a nurse came in. I could tell you how tall she was, what kind of hair she had, what she looked like. She came over, she adjusted my IV, she sort of looked at my arm to make sure everything was fine, and she walked out. I could see her, I could hear her. She was so real I could reach out and touch her, but it was a hallucination. And I found that out by ringing my call button and asking the nurse if someone had just come into my room. She said, no one's been here. And to this day, that memory is as real as any actual happening in my life. The reason I mention it is because if you don't know that this is something that happens to people following surgery or in a depleted state of physical health, you might think the patient is lying. A lot of times patients in nursing homes will say, that nurse, she just comes in here in the middle of the night and she steals things out of my drawer. Or there's a man with a gun and he comes and hides under my bed. This person isn't crazy. The things they're telling you are very, very real to them, even if they didn't happen. And you can be much more compassionate if you know that that's the history, that that's the source. You can also help by reassuring the patient and bringing them back to the current reality. I'd like to go on to the emotional challenges of cancer for the patient and the family. They're, again, often poorly understood. The patient looks fine. You say, how are you doing? And they smile and they say, oh, I'm doing okay. And you believe them. I'd like to give you a glimpse at what's going on inside their emotions when they're telling you they're fine. William Saroyan, just before his death, said, I always knew that people don't live forever. But somehow, in my case, I thought there would be an exception made. That about sums it up. The number one emotional challenge is fear. It was harder for me than dealing with the physical manifestations of treatment or the confusion or the decisions. Fear was enormous. About 95% of the cancer patients I've talked to over the years, probably 50 or so, will say fear is their number one challenge. I personally believe the other 5% of the patients are in denial and they're just not admitting their fear. What kinds of fears? The obvious one is the fear of death, and it's one that, especially in our culture, tends to not be addressed. And so very often the patient is dealing with this fear for the first time in their life. There's a fear of the dying process. How will it happen to me? Will I be at home? Will I be sleeping? Will I be in pain? There's the fear of pain itself. There's the fear of abandonment by friends or family or even medical personnel. There's the concern that when you stop being a hospitable hostess, people won't want to come and see you anymore. Or when you're confined to the house, nobody's going to care about you. Everyone's going to forget. An even bigger fear is the concern that you'll go into your doctor's office and he or she will say, well, there's really nothing more we can do for your cancer, so I guess you don't need to come and see me anymore. You can reassure patients that there will always be someone who will hear them, who will help them have the maximum living value from their life, even if nothing medically curative can be done. There's a fear of loss of dignity or personal worth that comes with being ill and the humbling experience of having other people assist you with personal care. And your personal worth may feel threatened because you don't feel like you can be a contributing member of society anymore. There's a fear of unfamiliar medical people, equipment, or procedures. I like to use the analogy of the school system. The kindergartner going off for the first day of school is facing a whole new world. They don't know who the teacher is. They probably don't know the other children in their class. They don't know where they're supposed to sit, how to line up. They don't even know where the bathrooms are. It's all overwhelming. Over the course of the first few weeks and months, they figure things out. They grow to be able to be competent kindergartners. They move on to first grade, and there's new and different challenges, new subjects to master. By about fourth grade, they're looking at essays and wondering how they're ever going to put together all those thoughts on a piece of paper. Maybe they're doing a multiplication problem in math that they're just not sure they can figure out. They move on to high school with a background in education, but there's new things to worry about. Will they remember their locker number? Will they remember the combination to the locker? Will they have enough time to get from that class on this side of the campus to that one on the other side? Will people like them? How will they fit in? Can they master the material? What courses should they study? By the time they get to college, however, most people have a pretty secure understanding of the factors that are needed in a learning environment. They've mastered the lingo, they have the study skills in place. They're ready to take on this new challenge. A person who gets a diagnosis of cancer and their family are like kindergartners that are suddenly thrust into the middle of a college campus. They don't know where they are, they don't know the people, They don't know the procedures. They don't know the culture. They don't know the conventions. What do you wear for a chemotherapy appointment? Do you need to bring your toothbrush with you? They don't know any of the terminology, and it's an enormous vocabulary to master. It's an awesome challenge. Fortunately, our library is one way that we help patients get past that sense of, I don't know the rules. There's a fear of being a difficult patient or a whiner. There's the concern that if you tell your doctor or your nurse how you're really feeling, they're going to think you're crying wolf or stop listening to you. I decided early on that I would tell my oncologist everything that was happening to me, whether I thought it was important or not. He had the knowledge and the experience, the expertise to tell me, yes, that's something that we need to deal with. That's a very important issue. Or, don't worry about it, it's not important. Or, you may feel like that for 3 days and then it'll be better. The most important reason, to be honest, with your medical care professionals is that there's very often an adjustment that can be made that will make you much more comfortable. I have to mention the special type of fear, which is the anxiety of waiting for diagnostic tests. That is probably the most vulnerable time of the entire cancer journey, the time between there might be something wrong and this is exactly the kind of cancer you have and this is what we'll do. A close second to fear as an emotional source of concern is the loss of control that goes with this illness. What do you not control as a patient and often as a family? You don't control most kinds of medical care. What the surgeon does while you're asleep is out of your hands. You don't control the radiation. You can't plan it. You can't plan the dose. You can't be sure the technician's doing it correctly. There's no guarantee that the medications in that chemotherapy bag that's going into your vein are exactly the ones you need. It requires a great deal of trust. You also may not control your independence, your ability to take care of your own toileting needs, to feed yourself, to select your companions. You don't control your job. If you are the mom in the household and in charge of small children, you may not be the one who's in charge of them anymore. If you are a boss at work or had outside responsibilities, someone else may need to step in and do those things for you. You don't control that. You certainly don't control your schedule, your calendar, or your agenda. You know, when the surgeon says, be there at 6 a.m., that's what you will do. The antidote to all this loss of control is the value of self-determination. It's very important that the patient be allowed and encouraged to make their own choices, to control whatever factors he or she can. Little things like which dressing room do you want to use? Would you rather be on the couch or in the bedroom? How much light would you like in the room? Do you want it dim or do you want it bright? What do you want to look at? Maybe what do you want to hold? I can remember bringing with me a small teddy bear when I got my radiation treatments. It was very consoling to do that. It's also very useful to affirm to the patient that they are the ones who need to decide how much to eat and what to eat. Often it's very, very difficult to eat. Food doesn't taste good and it's really a challenge. But that really ultimately is something that they need to be allowed to control. The patient should also control who visits them. and what the topic of conversation will be. And this is particularly relevant for people that are working in the cancer center as volunteers, because you often have a captive audience. If someone's waiting for a doctor appointment or sitting hooked up to an IV, they can't just change the subject or walk away from you. They have to be where they are. So it's up to you to be very sensitive to the fact that they may not feel like talking to you right now, and they have every right to not talk to you. It's perfectly okay. Most importantly, the patient has the right to control the use of their precious time. They are the ones who should decide if they want to take a nap, if they want to sit in the backyard, if they want to travel to see Aunt Martha, or if they don't. It's up to them. The third emotional challenge is dealing with grief. We tend to think of grief in terms of death or mourning after a person has died. But there's a lot of loss involved in this illness. There's the loss of old roles as a mother, a father, a helper, an employee. There's very often the loss of body parts, a portion of your colon, a breast, maybe a part of your face or your foot due to the cancer itself. And there's a loss of body function, perhaps your ability to have children. Maybe you have an ostomy. Your body is very different, and people grieve for that difference. There's a loss of self-image. I can remember on a bad day going into the bathroom and looking at myself in the mirror, feeling really rotten. And I looked in the mirror, and staring back at me was a person who had no hair at all. No eyebrows, no eyelashes, no color, and sunken cheeks, black circles around her eyes. And I looked at it and said, that can't be me. I actually raised my hand to remind myself that that was me, and it was okay that it was not the essence of who I was. It was just how I was looking at that point. But this is a loss, and it requires grieving. The last emotional challenge I want to discuss is emotional instability. We often don't realize how much energy it takes to filter out our emotional responses to the demands of daily life. You know, when you're sick or sleep deprived or have a migraine, you tend to be grouchy. Well, often patients in the course of this long journey may be grouchy too. They may have a decreased tolerance for noise. Even a small noise can be disruptive and almost painful. Often there's a decreased tolerance for confusion or a level of activity around them. It's very hard to cope with a change in routine. A predictable routine is an anchor in the midst of so much that's unpredictable. There's a decreased tolerance for physical clutter or disorder. I remember telling my kids, you know, for the duration of my treatments, you can't leave your stuff laying around because it's too much for me. I can't handle it. The patient wants to be able to be on autopilot without having to make additional decisions. The last dimension of health and illness is certainly not the least important. It is the spiritual dimension. Soul pain, pain in the soul, is as real and maybe more distressing than physical pain. We need to examine our culture's approach to the spirit. Too often you'll hear a comment like, she lost her battle with cancer, or we lost that patient on the operating table, or she beat it, she licked that cancer, as if dying equaled losing and living equaled winning. We need to realize that winning does not mean never dying. Winning is living fully right now. It's not a matter of religion or institutions, but rather acknowledging our universal human concern with something more. Each person must either grapple with these eternal questions or choose to exclude them from their life. It is an abuse of power when someone is so vulnerable to convince them to believe what you believe. It is, however, not only appropriate but often helpful to hear what they believe, what they think, to give them an opportunity to discuss their point of view about spiritual matters. Tony Long, a professor at UC Berkeley, summed it up well. In a horrible situation, what is most devastating is not the physical pain, but that you are inclined to think of yourself as utterly worthless. The question is, how do you retain any self-respect, any sense of your own dignity under such circumstances? The ancient Greek philosopher Epictetus would reply, even when things outside look as dire as they could be, you are still capable of thinking of yourself as a real human being who has something to contribute to yourself and to the world. I would say that's our job, to communicate that to patients at any stage of the journey. I'd like to spend my remaining time talking about communication do's and don'ts. As I was grappling with the enormity of a cancer diagnosis, surgery, recovery, chemotherapy, I heard many variations of this story. You have ovarian cancer? Oh, that's a really bad one. My Aunt Ethel had ovarian cancer. Poor thing. She was so sick. Those chemo treatments just made her miserable. She never did recover. It came back in her bones and in her brain. She just lingered on, skin and bones. It just about broke her husband's heart. They tried everything and they just couldn't help her. Can you imagine the effect stories like this had on me? I felt physically nauseated. I felt like someone had taken out a machine gun and summed up every worry I had and told me I should keep worrying about it. It was extremely unhelpful. And I'm passionate about what not to say. Number one on my list is do not tell horror stories. Any variety, any disease, it doesn't help.
My friend had that kind of cancer and she only lived for 3 months.
Second on my don't list is you should try. Throwing out advice about your pet cancer treatment or cure.
You should try a macrobiotic diet.
I had people telling me about shark cartilage. I had people telling me about embryonic umbilical cord infusions or bee pollen or all kinds of different ways that they believed my cancer could get better. The result of a comment like this is that it gives the patient one more thing to sort through. they're already working incredibly hard trying to get the information they need from doctors about the treatment that they're in the midst of, and adding additional concern is unhelpful. Please don't say, "I know just how you feel."
I know how you feel. I've had this cold for weeks.
That remark is never true. We can have an inkling of how someone feels. We can say, "I was in a situation similar to yours, and this is how I felt." But we never know just how that other person feels, because we don't have their history, we don't have their personality, we don't have their cancer, their particular disease. Be careful about assuming that you know how someone feels. Please don't compare and say things like, "You think that's bad. I had the flu and I was in bed for 3 days. I couldn't stop throwing up."
Yeah, you think that's bad? When I got my wisdom teeth pulled, I was miserable.
The patient is thinking to themselves, I'm looking at 9 months of feeling like I have the flu. This person really doesn't understand that they are belittling the patient by comparing it to something that's a relatively quick and easy situation. Never offer or ask for statistics. Mark Twain, the famous author, said, "There are 3 kinds of lies. Lies, damn lies, and statistics."
I hear only 10% of people die from this.
Statistics are useful for an overall population, but they don't ever help an individual patient. Because if the odds are 50% that someone with their disease will be alive in 5 years, and they're one of those people who are alive, they're 100% alive. If they're one of the percentage that aren't alive, they're 100% not alive. So in an individual case, it's far better and far less scary to not discuss the statistics at all. It should go without saying, but don't ever say, "So, how long have you got?" or "What's your prognosis?" You have no business asking that, and it is a really insensitive, uncaring comment. Please don't send "get well soon" cards or "you'll soon be back on your feet."
This card is so cute. Don't worry, you'll be fixed up in no time.
Because quite likely this person will not soon be back on their feet. This is a long journey. The positives, what does help? Active listening skills. Your goal is to understand the patient, not to have him or her understand you. I'd like to begin with nonverbal active listening skills. What are the things that happen before either of you opens your mouth? Your tone of voice communicates something to the patient. Do you sound angry, loving, rushed, bored? Watch your tone of voice. Pay attention to the timing between your comments and between the comments that the other person makes. Be aware of your body posture. If the person is sitting in a chair or laying on a bed or a gurney, sit down if you can. At least bend your knees. Do everything you can so that you are not towering over them looking down. At the same time, don't cross your arms and give the impression that you are an authority, but be soft and welcoming in your posture. Gentle, caring eye contact can be a great way to communicate. Just with the comment that in some cultures, eye contact, direct eye contact, is considered impolite. So follow the lead of the person you're talking with. The same is true of touch. In some cultures, touch is a great way to show you care. In other cultures, it is an invasion of privacy. Be careful of your distance from the person you're talking to. Some people want you very close, and some people need more personal space around them. Let the person you're talking with set the distance between you. Pay attention to your facial expressions and try to avoid showing in your face panic or fear or pity. How about the words you use? Honesty is key from the patient and from you. It's very important that you are both honest. If you don't know something, feel free to say, I don't know. Validate the patient's feelings. Feelings aren't good or bad. They just are. It's not that a person who's angry is a bad person or that anger is a bad feeling. That is where that patient is right now. And ignoring it or trying to talk them out of it is again unhelpful. It's far better to say, you really sound angry, and let them explore it, let them share it, let them feel that they are heard, whatever the emotion of that moment is. Allow the patient to direct the conversation. You should talk less than 50% of the time. This is very different from casual conversation on the street, because in that situation, we're very often preoccupied with what we're going to say next, rather than really hearing what the person is saying to us. In this situation, the people aren't asking you for answers. They just want to know that somebody cares enough to hear what they have to say. If you listen, very often they come to the insights they're seeking on their own. Allow silence. As I mentioned before, the patient tends to feel overwhelmed and confused and have difficulty thinking. If you allow silence, you let them have the time they need to process their concerns, to decide if they want to share something with you on a more personal level, or to choose the next topic they'd like to use. It's very important to watch for the nonverbal cues that may invite you to leave, like turning the head away, closing the eyes, rubbing the eyes, or yawning, or staring into space. Sometimes a patient will kind of rub their shoulder. All of these are ways for you to pick up the message, I should leave. If you suggest to the patient, oh, it looks like you're getting sleepy, do you need some rest? Would this be a good time for a nap? I'd be happy to stop back later. You save them the embarrassment of saying, would you please leave me alone? I'm maxed out. I don't want to talk anymore. Sometimes having someone to be with is the most important thing, without that person saying a word. While waiting for one of my surgeries, my husband could not be with me. It was a sudden procedure. And I called a friend, a special friend, that I knew would be a good companion. She sat with me. She listened when I wanted to talk. We spent a lot of time in silence. She looked at me. She didn't try to cheer me up. She didn't say everything's going to be okay. She just let me be and was with me so I was not alone. That's a huge gift. If you don't have the words to say, just being there can help a lot. When a patient is at the point where words no longer help because they're dozing or they're drifting in and out of consciousness, are there other things that can still communicate help? Smooth, clean sheets are wonderful. A gentle touch, sometimes some moisturizer on the lips. Music to listen to can be very calming, even if a person isn't fully conscious. Beautiful things to look at when they open their eyes. Family photos or artwork or a bouquet of flowers or some autumn leaves can really lift the spirits. To the patient, any patient, there's nothing more important than the assurance they are loved. In the end, that's the job description for all of us, volunteers or just whole people. Give love.